And good morning or afternoon, everyone, and thank you for joining this session today. My name is Allison Huckel, again, a former nuclear medicine technologist. I have since transferred to the industry side and am currently a clinical application specialist. Today, we will be discussing the value of cardiac PET, specifically with Rubidium-82. And as Lisa said, should you have questions, we should have a few minutes at the end of the presentation to get those answered. So here are our objectives for this presentation. We will begin with a basic introduction to myocardial perfusion imaging and PET imaging. We will then discuss SPECT MPI versus PET MPI and PET MPI's advantages. We'll then dive into cardiac PET specifically with Rubidium-82. And lastly, we will discuss some things to consider when improving or starting up a cardiac PET program. So before we jump into the details of how valuable Rubidium-82 cardiac PET is, here is a snapshot of the projected outlook of PET MPI. So positron emission tomography, or PET, is increasingly being applied in the evaluation of myocardial perfusion imaging. And we can see here from this data that the market is trending in favor of cardiac PET. In fact, in the last 5 years, cardiac PET volumes have been growing at double-digit rates, and they're forecasted to keep growing over the next 5 years. And so this is why we're here today discussing the value of cardiac PET, more specifically with Rubidium-82. Our first topic of discussion is PET MPI. So let's start with MPI. What exactly is it? Myocardial perfusion imaging, or MPI, is a non-invasive nuclear medicine exam that's used to identify and evaluate coronary artery disease, or CAD. The images obtained from the exam are called our perfusion images, and these images show which area of the heart are being supplied with blood. The set of images are presented in the short axis, which is the top set of images, and if we reference the far left heart there, this is the area that we're looking at. The second set shows us the horizontal axis, and lastly, the vertical long axis, and this allows physicians to evaluate the heart in its entirety. So while the PET market is trending upward, SPECT is still very much prevalent and is still the most common modality used for myocardial perfusion imaging. The agents used in a SPECT study are either technetium or thallium, with technetium being by far the most common. The patient will receive one rest dose and one stress dose, each followed by a set of images. And while the exam will take nearly 3 hours to complete, the patient's only on the camera for about 5 to 20 minutes per set of images. And this is depending on the camera type. For example, the new CZT cameras allow for low dose or half-time imaging. It's also prudent to note that in certain cases, the SPECT scan may be completed over 2 days, and this is depending on body habitus and the doses needed to obtain quality images. When we're doing a SPECT MPI, the patient can be stressed 2 different ways, either exercise on a treadmill or be given pharmacologic intervention if they are unable to perform the exercise portion. SPECT MPI is a very well-known exam that has been extensively validated. It is a cost-effective method of performing myocardial perfusion studies, and the guidelines are published by professional societies and the protocols are standardized. However, when SPECT MPI is compared to other modalities, SPECT has much longer protocol times. Attenuation correction isn't always used, and it uses suboptimal tracers, which results in increased radiation exposure, not only to the patient, but also to the staff. An improved method of performing a myocardial perfusion study that addresses the disadvantages of SPECT is PET. So here's a brief overview of what positron emission tomography is. PET is an imaging technique that measures physiological function. It offers quantitative analysis that allow relative changes over time to be monitored as the disease progression evolves, or excuse me, the disease process evolves. These PET cameras measure the distribution of positron-emitting radionuclides, and these specific radionuclides are used because of their unique tomographic capabilities. So to divulge a bit more about PET and the radionuclides, PET allows for increased resolution due to the characteristics of the isotopes that we used. Once the isotope is injected, whether it's F18, rubidium, N13, O15, they all travel a certain distance or a positron range prior to annihilation. So what is positron range and what is annihilation? The black box there describes positron range, and it's the average distance a positron travels before annihilation. That's its positron range. And the positron range is determined by the energy with which the positron leaves the nucleus. The less it travels in tissue, the higher our resolution. And all of the isotopes have differing positron ranges. So F18 will be different from rubidium, which will be different from N13. They're all different. Annihilation is where two 511 keV photons are emitted 180 degrees from each other. They then interact with PET detectors where a series of events occurs and images are then produced. So let's discuss our camera types. When it comes to a PET camera, there's various types. We have analog PET, we have digital PET, we have 2D and 3D imaging, we have a dedicated PET camera, or you can have a PET CT. All of these cameras can be used for myocardial perfusion imaging. But let's look at analog PET imaging first. So I mentioned on the previous slide, a series of events occurs after annihilation, after those two 511 keV photons are emitted. With analog PET, the series of events is that the incident photons, those two 511 keV photons, are converted to visible light via their interaction with scintillators that are coupled with photomultiplier tubes, or PMTs. Those then generate an electronic signal. So that's the series of events that occurs within an analog camera in order to produce our images. With an analog camera, you can image in 2D or 3D. With two-dimensional PET imaging, those cameras utilize septa, and these septa absorb, scatter, and random coincidences. However, they require larger doses in order to obtain enough counts for those images. With 3D PET cameras, we don't have the septa, which increases the number of accepted incident photons. This allows us to have decreased dosing. So while imaging without septa increases our sensitivity, since we're accepting so many more counts, it also increases the detection of our scatter coincidences. Most cameras produced today are in 3D. However, 2D cameras are still very much prevalent in the market and can be used in cardiac imaging. So we discussed analog in 2D and 3D. I had also mentioned that there is a dedicated PET camera, or we have a PET CT camera. Dedicated PET scanners utilize a smaller gantry, which in turn decreases our overall field of view. These dedicated PET scanners also utilize rod sources for positioning and attenuation correction rather than a CT. So the scanner has these radioactive rod sources within the system that are extended when we need to perform a transmission, so our scout scan for positioning and then our attenuation correction imaging. But the sources are then retracted when we're doing our emission scan. With a PET CT, these systems have the undesirable feature of accepting more random and scatter coincidences due to their shorter detector ring. However, they are able to have faster imaging time with the incorporation of the CT. With the PET portion remains the same, the positioning and the attenuation correction scan is significantly decreased. So with rod sources, we're looking at a scout scan taking maybe 60 seconds, followed by another 3, 4, or 5 minute attenuation correction scan. The amount of time these images take will depend on how new or how hot the rod sources are. The older they are, the longer those transmission scans will take. Again, a PET study can be completed on either type of camera. The protocols are just slightly different. The latest and greatest type of PET imaging is digital PET. And these systems use digital photon counting detectors versus the photomultiplier tubes on an analog system. These digital photon counting detectors convert the scintillation directly to a digital signal and then create our images. These cameras have the highest sensitivity, which decreases image time and also the dose necessary to obtain quality images. The main takeaway when we're discussing PET camera types is that a PET MPI perfusion study can be done on any type of camera. It should just be taken into consideration when putting together our imaging protocols. So now that you have a basic understanding of PET MPI from isotopes to cameras, let's jump into the advantages of cardiac PET itself. So when is cardiac PET preferred versus when is it recommended? Cardiac PET's preferred as a first-line test for patients who are unable to complete an exercise exam, patients with known or suspected CAD, and patients who meet appropriate criteria. And it's also a new first-line test during COVID, which I will discuss on the next slide. Cardiac PET is recommended in patients of special populations, such as younger patients, higher risk patients, and patients who have certain body characteristics, such as high BMI. And cardiac PET is also recommended for patients who have received a previous poor quality stress test. So as I mentioned on the previous slide, cardiac PET is a first-line test during COVID, and this article was published last year in 2020, and it concluded that cardiac PET, if available, may be preferred due to its rapid throughput, and it helps minimize the time spent in the department. It also helps to minimize droplet exposure associated with treadmill stress testing when doing SPEC studies, because when we're using rubidium, we can only use pharmacologic intervention, which I will talk about shortly. And lastly, if CT images are acquired for attenuation correction, these images can also be evaluated for possible COVID-19 pulmonary findings. So there are many advantages to cardiac PET, from high diagnostic accuracy, high quality images, low radiation exposure, the added information that can be obtained, and also its prognostic power. We'll discuss each of these bullet points at length in the following slides, and we will begin with the first bullet point there, high diagnostic accuracy. So with cardiac PET, we have increased diagnostic accuracy because we have high sensitivity, which improves our disease findings, specifically in multivessel disease. The cardiac PET also improves detection if disease is not present or high specificity. Thus, overall, we are increasing our diagnostic certainty. When we have the high sensitivity and high specificity, patients aren't undergoing unnecessary exams and procedures, and this in turn reduces our overall medical expenses. When using rubidium, you obtain true peak stress information since we inject the tracer at peak hyperemia and are acquiring images simultaneously. And again, we'll discuss this a little bit later in detail. The last bullet point there, calcium scoring may also be obtained if using a PET CT, and this is helpful when perfusion images are normal. The graph on the right displays results from 3 different studies that validate the use of relative quantification with normal limits for myocardial perfusion PET for the detection of coronary artery disease. And even with a 50% stenosis, the sensitivity and specificity is increased as compared to SPECT. Here are just 2 examples of the high diagnostic accuracy, starting with A, that top set of images there. The SPECT study is showing a fixed defect in the inferior wall. However, this defect is absent on the rubidium PET study. And this is an example of improved specificity when doing cardiac PET. B, the bottom set of images there, the rubidium study indicates defects in the anterior and inferolateral walls where those white arrows are. However, this is not clearly shown on the technetium SPECT study, and this is an example where PET is showing improved sensitivity. Again, these are just 2 examples of increased diagnostic accuracy when comparing SPECT to rubidium PET. The next advantage of PET MPI is consistently high quality images. So these PET images are extremely high count images, and these high count images increase our spatial resolution. It's also to note that when a cold saline flush is introduced immediately after the injection, image quality is increased even more. PET also always uses attenuation correction, whether it's using the rod sources in a dedicated PET or using the CT in a PET CT. So you know you're always getting reliable and accurate images. And lastly, PET is relatively unaffected by body habitus. The figure on the right is taken from a study comparing PET versus SPECT MPI in patients with high BMI. And it indicated that patients who have a BMI greater than 30, their image quality is relatively unaffected and still highly accurate when using cardiac PET. So I mentioned a cold saline push on the previous slide, which this would be vendor specific. However, this figure demonstrates how a cold saline flush is given, and this is specifically after a rubidium infusion. So rubidium is a generator produced and it has a very short half-life, so we need an on-site generator and infusion system. So what this image is displaying is with an infusion system, we pull saline from the saline bag, we pump it through the tubing via a pump, and then the saline will either go to the generator where we pull off our rubidium, and that goes directly into our patients who is already positioned on the table. And then once that rubidium is complete, this little valve shuts off and it opens, the saline opens directly to the patient where we immediately give that cold saline push immediately after that rubidium infusion. The volume of saline given is dependent upon which vendor. You can either give a standard volume or something more customizable, and that again is vendor specific. The second image here is taken from a study that was performed at the Ottawa Heart Institute, and it demonstrates that the post-injection saline push increases our target to non-target ratios, or myocardium to our background, by nearly twofold, and image quality is vastly improved. We can see clearly the difference with the push, the top set of images there. We have very clean, crisp, very little extra cardiac uptake versus without the cold saline push. The bottom set of images have much more background noise there. Again, I think the image speaks for itself, but we can clearly see image quality is vastly improved when the saline push is incorporated. Another advantage to cardiac PET, which may be surprising to some, is radiation exposure. So while some may think radiation exposure would increase when you're transitioning to PET due to just the mere energy of the PET isotopes, the opposite is true. And on average, the blue box down there, PET MPI has nearly 2 times less exposure than SPECT. So if we look at the table here, the top 2 numbers there is indicative of a rubidium, of an entire rubidium rest stress study. So the 2 millisieverts of exposure here is when we're talking about a 3D PET camera versus a 2D PET camera, about 4 millisieverts, still significantly lower than any of these technetium studies down here. So even with lower doses given, with technetium, our rubidium PET numbers, millisievert numbers, are still significantly lower than our SPECT exposure. This is another study that was performed. It was determined that the exposure for an entire study, so your entire rest and stress study, is only about 1 millisievert. From this study, it's to note that it was performed on a 3D camera, and it also utilized weight-based dosing. So it was probably much less than the 25 millicuries that was given, or the 50 millicuries that was given on the previous slide. These numbers will increase slightly if you're using a 2D camera. We have to give slightly higher doses, and or if you're using that standard dose of 30 millicuries or 40 millicuries. Short acquisition time is another advantage of PET MPI. Rubidium PET, again, can be completed in just about 30 minutes, while a technetium SPECT study will take nearly 3 hours to complete. This is what a typical rubidium Rb82 protocol would look like on a PET CT. So what we do initially is a scout scan for positioning, followed by our attenuation correction scan. We would then inject the rubidium to the patient and do a series of images after that. Once those images are complete, we would then stress our patient with a pharmacologic interventional agent, followed by a second infusion of rubidium. And then we would do our second set of stress images, followed by an optional CT for attenuation correction at the very end. Again, this entire study, we would have the patient only on the table for about 30 minutes. So short acquisition time is extremely beneficial for a lot of patients, specifically our emergency department patients. It's a test for emergent patients who need results very quickly. Our claustrophobic patients. So much shorter imaging time makes it easier for these claustrophobic patients to tolerate. Patients who have trouble holding their arms over their head, so older patients or patients who have had surgery, the shorter we have them on the table, the less chance we have of patient movement. When we have a lot of patient movement or motion in our images, this decreases our overall image quality. So the shorter time that we have them on the table, the less chance we have of that happening. So far we just have discussed the diagnostic accuracy, our increased image quality, low radiation exposure, and our short acquisition time. The next few slides are going to discuss some added benefits when incorporating cardiac PET. So absolute myocardial blood flow, myocardial flow reserve, and calcium scoring. And we'll start with absolute myocardial blood flow. So traditional myocardial perfusion imaging assumes that the area of highest myocardial uptake is normal. This normal area provides a reference for the entire rest of the study. However, we have potential for misdiagnosis here, especially in multivessel disease and if there's microvascular abnormalities. PET also has the ability to quantify absolute myocardial blood flow for each coronary artery and globally. This also allows for the additional myocardial flow reserve information that also may be referenced as coronary flow reserve, CFR, or MFR. So what is flow reserve? Flow reserve signifies the ability or degree to which the heart is able to improve its blood flow in response to vasodilation or being stressed. Flow reserve is the measurement of how well the flow is increased from rest to stress. So why do we even want these measurements? This is a study that proved an improved risk assessment. So what this illustration is showing is subjects were placed into categories of low, intermediate, or high risk of cardiac death, depending on various risk factors. Flow reserve was then implemented, and this is showing how these patients were reclassified after the implementation of flow reserve. The most affected risk category was the intermediate group, with over 50% of the intermediate risk patients being reclassified after the addition of this flow reserve information. So MFR CFR is an extremely powerful independent correlate of cardiac mortality and provides meaningful incremental risk stratification. Again, this is a very brief overview of what absolute myocardial blood flow and flow reserve is. We will actually have an entire separate presentation covering this at length. I just wanted to note that these are an added benefit when we implement cardiac PET. The last added benefit is calcium scoring, and I touched on this a little bit earlier. This would be specific to our PET CT cameras only. And again, this doesn't add any additional scan time, but it does improve the overall or improve our identification of obstructive coronary artery disease. And again, only can be performed on a PET CT. This is done during the CT portion of the exam. So the final advantage I will talk about of cardiac PET is prognostic power. And prognostic power has been well evaluated. These are just a few of the many articles that have been published from heart transplant patients, obese patients, diabetic, younger, older patients. Cardiac PET has added value to all of these patient populations. So as I stated, regardless of patient population, PET provides high discrimination of risk stratification in patients who need myocardial perfusion evaluation. From obese or non-obese, men, women, diabetic patient population, patients with renal dysfunction, and heart transplant patients, cardiac PET has added value to all of these special patient populations. So now that we discussed the advantages of cardiac PET, let's dive a little bit more into cardiac PET specifically with rubidium. So while SPECT is still very much utilized, PET is the improved way of performing a myocardial perfusion study, with rubidium being the most common agent used. I noted before, but just to reiterate, an entire rest stress study can be performed in just under 30 minutes. And the stress test option for rubidium PET is only pharmacologic intervention due to rubidium's half-life being only 75 seconds. So I had mentioned a few slides ago that rubidium is generator produced. So with the 75-second half-life, we don't have time to elute the generator, drop it in the dose calibrator, get the patient off the treadmill and positioned under the camera, and then inject. So this is why we can only do a pharmacologic intervention. The patient is already laying on the table, hooked up to an IV, and we use pharmacologic intervention and inject our rubidium at peak hyperemia. So let's compare some advantages and disadvantages of Rb82. So with an on-site generator, we have an on-demand supply. We aren't relying on a pharmacy to get us doses. If you have the patients, the rubidium is already there with very few limitations on the number of patients that can be performed each day or over the life of that generator. Again, our short protocol times, which we have discussed, radiation exposure decrease for both the patient and occupational worker as compared to SPECT, that I already touched on as well. We have that high target to non-target ratio with the low extracardiac uptake. And then depending on manufacturer used, a constant activity infusion mode may be used for reproducible myocardial blood flow measurements, which we'll discuss here shortly. Some disadvantages of rubidium. So despite rubidium's first pass extraction being slightly lower than other PET tracers such as N13 ammonia, the rubidium is retained in the myocardium longer than those tracers. Again, we discussed, but we can only perform pharmacologic stress studies on these patients. And with a slightly higher positron range, which I discussed much earlier in the presentation, with a much higher positron range than N13, there is lower spatial resolution. However, reconstruction and processing filters help to alleviate that disadvantage. Cost. So while startup cost of cardiac PET labs are very high, unlike other PET tracers, rubidium costs decrease with higher clinical volume. So the tracer cost is fixed and independent of patient volume. So the more patient or the larger patient volume that you have, the lower per patient cost. So just a little bit more information on rubidium itself. Rubidium is the most widely available agent that's used for PET MPI. Rubidium is a potassium analog, and it's produced, again, with commercially available generators. Rubidium is made by the decay of accelerator-produced strontium-82, with strontium-82 being the parent, rubidium-82 being the daughter, if you want to compare that to like Molybtech. Molybdenum-99 is the parent and technetium being the daughter. And lastly, the half-lives, the parent, the strontium-82 half-life is about 25 days, and the rubidium half-life being just about 75 seconds. So generator columns are loaded with strontium-82. So tin oxide column loaded with strontium-82, which is tightly bound. The bond is broken when strontium-82 decays to rubidium, so decays to its daughter rubidium-82. When we flush the generator column with saline, it then pulls off the rubidium from the column and it is injected into the patient as rubidium chloride. The rubidium, being a potassium analog, is retained according to tissue perfusion, which makes it an ideal tracer for myocardial perfusion imaging. So again, rubidium chloride, it requires an on-site generator and elution system due to its short half-life. And depending on manufacturer use, the generators were replaced every 4 to 7 weeks. So every 4 to 7 weeks, you would get a brand new generator that you would install into your infusion system. When the generator is eluted with the 0.9% sterile sodium chloride, it produces the Rb82 chloride solution that's injected directly into the patient. So this image here is displaying if you were to cut a rubidium generator in half, this is what it would look like. It sits in a thick shielding, but the strontium is loaded onto the column there. When we pull saline from the elution system through the tubing, it would go in through the inlet. We would pull off our rubidium chloride and inject that directly into the patient who was already positioned under the camera. So how do we dose and how do we inject our rubidium? So you can either use a fixed dose or a weight-based dose, and the user can select the appropriate millicurie per pound increment depending on the elution system used and the camera that you have and your imaging protocol. A few things kind of go into that. And there are also a couple different options as to how the Rb82 is infused. We can inject it kind of in this square wave or this constant activity injection profile, or we can inject it as a bolus infusion or by a flow rate, kind of a constant flow infusion. So what's the difference between these two infusion modes? So constant activity or the square wave injection profile on the left there allows us for consistent and reproducible injection profiles regardless of generator age, while also minimizing detector saturation. So this decreases our camera dead time and allows us to image more true counts. And this would come into play specifically when we're doing blood flow imaging or kind of that first pass imaging. With constant flow or constant time or some sort of bolus infusion profile, your injection profiles will be dependent upon the age of the generator. So while there's a true bolus at the beginning of generator life, because we have all of this activity available to us, we can pull it off the column very quickly and inject it into the patient very quickly. So that is true at the beginning of generator life. As that generator ages, it's going to take longer and longer to pull off that rubidium. So our infusion profiles will be ever changing over the life of that generator. It's just something to take into account when you are deciding which protocols you're doing, if you're going to be doing blood flow imaging. Just two different ways you can inject your rubidium, and it's kind of site preference on that. So this here is a position paper that was released by ASNC and the SNMMI with recommendations for myocardial blood flow quantification. This paper addresses some key techniques and technical factors that should be taken into account to perform accurate myocardial blood flow quantifications. And it specifically mentions that consistent tracer injection profiles improve the reproducibility of that myocardial blood flow measurement. So what does a typical day in a cardiac PET lab look like? With an on-site generator, daily QC must be performed every day that you are going to be using your generator. So it must be performed every 24 hours or every day that you're going to be using it. Once that's complete, you have the ability to essentially perform a patient every 30 minutes as long as you have the staff available. So here, this is just an example that I put together. I have patients on the table every 45 minutes just to give some leeway between patients. But again, this will depend on how quickly you can get them through, will depend on how, on the available staff that you have. So do you have someone there starting your IVs, doing informed consent? Do you have a stress tech? Do you have an EKG tech? You obviously need a nuclear medicine technologist. And then someone to run your stress portion? So do you have an exercise physiologist, an MD, a fellow? Do you have someone there on site to run the stress portion of that exam? Again, this is just an example daily workflow. Either perform daily QC at the beginning or the end of your day, and then begin your patients. So regardless of elution system used, there is flexibility in your generator quality control. This is something that you would want to be doing, or that you need to be doing and have to be doing every single day that you are using your rubidium generator. So just an example of daily QC workflow. The first 15 minutes, you are just setting up the elution system to run kind of the main event. So we want to empty our waste container, we want to hang our new saline supply, install our new tubing, some sort of setup verification, make sure the components of the system are working properly. If you have an onboard dose calibrator, you would want to run a quick constancy calibration before we get set up for kind of the main event, which is our generator flush, our generator calibration, and then our strontium breakthrough. So for our generator flush, all it will do is we're just going to pull saline. It's going to go across our generator column to our waste container. We just want to clean off any impurities of it sitting overnight or over the weekend. After that, we then want to go into the calibration. So what we will do is we pull off as much rubidium in a specified volume amount. And that is the activity, whatever you pull off in that volume is the activity you have to work with for that day. So you pull off as much as you can, and then that's what you have to work with until you run QC for the next time. So I had mentioned, so we don't have time to elute the generator, drop it in a dose calibrator, and then inject it into a patient. So we also need to calibrate our activity counter. So the PM tube that is essentially reading our doses to our patients, we need to calibrate that to our dose calibrator to ensure that we're getting accurate doses. So kind of twofold there with the calibration. And last but not least, we have our strontium 82-85 breakthrough. Again, this is something that we want to test for every time that we are using the generator to ensure that we are giving safe, accurate doses to our patients. So with a generator, there is always going to be a little bit of the parent isotope in the eluate, but we are limited in some capacity as to how much can be in that. So United States Pharmacopoeia, USP, sets certain limits of what is allowable to be in the eluate. And then manufacturers take it a step further and say, well, if you reach X amount, we're going to make you do additional daily QC. And if you reach, say, 50% of that USP breakthrough, you are essentially expired and you can no longer use that generator, just for safety of the patient, for the occupational worker, for the manufacturer. But again, it's something that we want to be testing for every day to ensure that the eluate that we're giving our patients is safe. So cardiac PET protocol example. This is just an example of a PET CT protocol. You have already seen this image once. And this would be slightly different if you are using a dedicated PET scanner. So it's to note that PET images are gated, and patients also need to be prepped prior to beginning the exam. So we want our IV started, we want our EKG patches set, we want them using the restroom, we don't want them up and down off the table once we have them positioned. But again, we would begin with a scout scan for positioning, followed by an attenuation correction scan. And then we would inject our rubidium and we would scan for somewhere between 5 and 7 minutes. If we are going to do the blood flow imaging, that occurs during the first 2 minutes after injecting the rubidium. So if you're only doing perfusion imaging, you essentially just cut off the first 2 minutes and delay when you are starting your perfusion imaging. So when you're incorporating the blood flow and those flow reserve measurements, it doesn't extend any part of your protocol time. But again, we would scan for those 5 to 7 minutes. After that, we would inject our pharmacologic intervention, and the vasodilator protocol should be referred to whichever manufacturer or PI that you are using. When we are ready to stress, so we would inject that, we would inject our rubidium at peak hyperemia, and then that is followed by a second set of somewhere between 5 and 7 minute images, and then ending with a second attenuation correction scan. If you are already an established department and your techs are extremely comfortable, you could drop off that second CT scan if your patient doesn't move a lot while they're on the table. That would be optional and just another way to decrease patient exposure even more. So you've seen an example of a rubidium PET MPI protocol, but here are the published PET MPI guidelines. So rubidium PET MPI has been well evaluated to give you confidence in this modality. So from dosing, which will be dependent upon camera type and infusion system that you're using, to your image delay and image duration time, any attenuation correction that you're using, and even image reconstruction, there's guidance to help you set up your protocol. So now that you have kind of an understanding of the advantages of cardiac PET and an understanding of rubidium PET MPI, let's look at a few case studies. So clinical case 1, we have a patient history of an 80-year-old female, 167 pounds, shows recent ECG abnormalities, suspicious for coronary artery disease, questionable areas of ischemia, and the patient was referred for an exercise SPECT MPI study. A dose of 37 millicuries of technetium was given to the patient, equaling about 10 millisieverts. And the interpretation was mild LAD ischemia, or was it an artifact? It's uncertain if there is an LAD defect or if this is an artifact interfering. So uncertainty exists, and it is recommended for the patient to then go in for a PET MPI. So a rubidium PET study was performed approximately 1 month later on a 3D PET camera. This patient was dosed using a weight-based dosing of 0.12 millicuries per pound. Again, the patient's weight was 167 pounds, so her dose was roughly 20 millicuries, equating to only about 2.5 millisieverts. The interpretation is that it is certain there is a moderate LAD defect plus a mild circumflex defect. So after the PET MPI scan was performed, there's much more certainty for this patient and their care going forward. Clinical case 2, we have a patient history of a 72-year-old male, 203 pounds, patient presented with type 2 diabetes and possible angina. The rubidium PET was performed towards the end of generator life on day 57. With this specific manufacturer, the generator lasts 60 days, so this patient was done just 3 days before expiration of that generator. This patient was given 21 millicuries, and it indicated that the test was negative for angina, but showed ischemic changes on the ECG. Their EF was 64% at stress and 61% at rest, and this exam indicated a normal distribution. What this is representing is that we have quality images even at the end of our generator life. For our final section, we will discuss a few things that need to be considered, whether you are a first-time rubidium user or even an established department. There's many logistical, equipment, and staffing things to consider. So some equipment considerations, we have PET camera, the rubidium generator, some extra equipment and processing software. So for the PET camera, how much space do you have? Do you need to build out space? Are you going to be using a dedicated PET camera where we utilize those rod sources? Are we going to use a PET CT, or are you going to go for a digital PET scanner? For camera time, is this going to be dedicated to cardiac only, or do you want to share it with some oncology patients? Technologists also need to be trained on quality control of that PET camera. How long does that take? What's the timing for that? When are we going to be performing that? For the rubidium generator, you need your technologists and your physicians. You need RSO training on the generator and elution system. Daily quality control, just something to consider. Dosing, how are you going to dose your patient? And that will kind of revert back to the PET camera that you're using as well. Generator cycle, again, that will go back to how you're going to be dosing and the PET camera that you have. Some equipment we would need an ECG monitor, an automatic blood pressure cuff. We want the radiolucent leads and wires. a standalone display system, just some extra things that we need for the stress portion of that test. And lastly, some processing software. So you need a workstation for processing. Do your technologists need to be trained on this new processing software, or do your reading physicians need some training on that processing software? You'll see under all of them, we have cost. Cost goes into everything, whether it's the PET camera, the generator, the software, the equipment. There's all going to be some sort of startup cost with that. Some staff considerations. Available staff, the technologist, your stress test, and your patients. So from available staff, do you have someone who will be scheduling, billing, pre-authorizing these exams? How many technologists do you need? 1, 2, 3. Who will prep your patient? Do the informed consent, start IVs, place your EKG leads, and then someone as your stress test supervisor. So for your technologist, is this a PET camera or a PET CT? If it's a PET CT, who will perform the CT portion? Kind of what are your state regulations for your technologist? For the stress test, who will prep and supervise the stress test? A physician, a fellow, exercise physiologist. Which pharmacologic stress agent do you want to be using? You can use any of them, regadenoson, adenosine, dipridamol. You can use any of them. We just need to kind of tailor our protocols on as to when to inject the rubidium. And who will give the vasodilator? Is it going to be the person supervising the stress test? Will it be the nuclear medicine technologist? And then some considerations for your patients. Are they claustrophobic? Will they be able to be in the camera for about 30 minutes? Are they able to raise their arms over their head? Are they prepped properly? Just some things to take into consideration there. So there's lots of decisions to be made and many moving parts once the department is up and running. These are just a few of the items to take into consideration. So we've reached our final slide here. So let's just go over what we have discussed. When performing cardiac PET with Rb82, we know that we have high diagnostic certainty for coronary artery disease. We have increased sensitivity and increased specificity. Overall, we have better image quality, which increases our diagnostic confidence. Again, decreased radiation exposure as compared to SPECT. We have the faster scan time, so increased patient throughput, improved patient comfort and convenience, decreased motion artifacts. All of that incorporates or are positive things when we're talking about our faster scan time. That increased prognostic power, regardless of your patient population. Attenuation correction. When using a PET camera, we know we are always going to have attenuation correction. And then last but not least, we get routine quantification of absolute stress flow and rest stress flow reserve, which has that added diagnostic and prognostic value. So thank you for attending this, and I believe we should have time for 1 or 2 questions.